TMB is a very interesting biomarker. It's been studied on so many patients now. Many of the assays that are being used have been cross-validated. So I think there's no doubt that tumor mutational burden, the number of mutations per megabase of DNA, are going to correlate with outcome for patients getting immunotherapy. Whether it will differentiate immunotherapy versus chemotherapy or immunotherapy versus a combination immunotherapy is still a matter of investigation. I think there are some hints that you can use it to decide who might get combination immunotherapy, for example, ipilimumab, nivolumab, but I think we're still waiting for results from larger trials. But we're keeping a close eye on this. I think it is going to be part of the equation. We're going to use tumor mutational burden, PD-L1, and maybe use those in a dichotomous way. If patients don't have any PD-L1 and no TMB, that might be a very bad group that we really need to think about how to shake up the immune system and get that working. If someone's positive for both, one might hypothesize that might be the group that might do best. And then there's the middle group, and you have to figure out how much therapy do you need to give. Because as you add more therapy, you add potentially more toxicity. But I think the TMB data are quite compelling. Ultimately, there will need to be more prospective studies done, but I think the data that are coming out of the Checkmate trials are really important, certainly from the atezolizumab trials as well, the Empower trials and so forth. So I think it's going to be an important part of our armamentarium.